Okay, hi, I'm Daniel Thompson and I'm a research officer and data scientist at Swansea University. And I'm going to talk to you today about the Green and Blue Spaces project, where we're looking at the impacts of green and blue spaces on mental health and well-being. I'm going to specifically talk about the data sources and the data linkage and some initial insights from our data linkage. Firstly, what exactly is a green and blue space? It is a term used to group together any place where you'd go and spend time outdoors, such as a beach, a park, woodland, and a river. And I want you to quickly think about how you interacted with these green and blue spaces during a time period where there were restrictions on where we could go and when we could go and the number of times we could go to places. And I want you to think about why you chose certain locations and how it made you feel when you were able to go to them. I ask this because there's a strong evidence base between a positive interaction between our mental health and visiting green and blue spaces. And there's a positive associations by the number of times we visit a green and blue space. And this evidence base is based on a number of studies. However, the studies usually are using cross-sectional data and not assessing the changes in green and blue space over time, and also the changes in an individual's mental health and how these two changes may be associated. That's where our project comes in. We're looking at the impacts of a change in green and blue space on an individual's mental health and well-being outcome. And we're doing this for the population of Wales. So we've got a very large population group between the years of 2008 and 2019, which enables us to capture subgroups that have previously potentially been missed due to their smaller population sizes. So in order to assess these changes in green and blue space and their eventual outcomes on mental health and well-being, we are answering these two research questions, and we're building this longitudinal cohort where we're linking two key data components. That is the exposure metrics, which provides the amount of green and blue space within an individual's residential area, and also the individual's health records to identify whether they are at risk of a CMD or not. So our cohort captures anyone living in Wales who is aged 16 and over, registered with a GP, providing care and GP records to the SaIL data bank, and it also has a linked residential address in Wales between the start and end date of our study period. We have then split the study period up into 3 monthly time periods, so we end up with 47 time periods, and for each individual and for each time period we identify if that individual is at risk of a mental health disorder. This is by looking at their health records. We also identify if that individual has a place of residence and get that place of residence, and it is through that place of residence that we can link an exposure metric, so the amount of green space in the area or the amount of access to certain parks or woodlands. This is all done anonymously, but let's have a look a bit more detail at the exposure data. So we've derived a number of exposure variables, so EVI, the mean ambient exposure within 300 meters of an individual's home, so the EVI and NDVI, and then also the potential for an individual to visit a green space within an area. So we're able to identify what type of green space is within 800 or 1600 meters, the distance to that space, and also the average size of that space. So we've derived this from a number of geographic data sets, and we can then link it to each residence in Wales and then anonymously link it into our SaIL data bank where we get access to an individual's health records. And it is through this health records and through the various data sources that we are able to anonymously link through that we can attain an individual GP records and identify whether they're at risk of a CMD. We're also able to identify key confounders such as the age, the individual's deprivation, gender, rurality, and whether they've had any hospital admissions recently or gone to A&E, and also comorbidities. On top of that, the key other aspect is identifying their residential address. And it is through this residential address that we are able to link the exposure metrics to their individual health records. So this is all the core data sets that we then compile into the SAIL data bank, and I'm able to build up this cohort, which would eventually look like this for each individual. So this is an example individual who entered the cohort in 2008 and left in 2019. They moved house twice, and they also are identified as at risk of a CMD, a common mental health disorder, during one time period. So for each individual, and for each individual in our cohort, we have this where we're able to identify for each quarter whether they have a CMD and an amount of exposure linked to them for each year they are in the study for. The CMD is flag is updated quarterly, and the exposure data is updated yearly. However, if they move house within the year, then the exposure data changes when they move house. So we've been able to capture 2.8 million people, and which is equated to over 110 million rows of data, and provide an average follow-up of 8 years. Just some key data snapshots from this cohort. So 28% of our cohort are diagnosed or receive a symptom of CMD. And this is predominantly females, with 62 to 38% split. Interestingly, those who are diagnosed, 65% are diagnosed more than once. This is a key aspect of being able to look at it longitudinally. We're able to see their continuous interaction with their GP. So we're able to identify that an individual has had a diagnosis and then they've had a second diagnosis, but we're also able to identify that of those who do have a secondary diagnosis, that there is a change in their diagnosis. So they may go from anxiety to depression diagnosis, or vice versa. Females are more likely to be identified as at risk of CMD compared to males, and those living in the lowest deprivation quintile are more likely to be identified as at risk of CMD compared to other quintiles. In terms of exposure, our age group that observes the largest amount of ambient exposure around their house, residential area, people who fall into this age bracket, compared to those between 21 and 30 with the least amount of ambient exposure. And another key aspect that we want to look at is this longitudinal and the change in the green and blue space. And it is likely that most of our change in exposure is going to be observed through an individual moving residence. And it's great to see that 41% of our cohort are moving house at least once during their time in the study. So let's look a bit more detail at the exposure. So here we've got a plot of the ambient exposure within 300 meters for every individual in the cohort and for every quarter. And I've split it up into a low amount of exposure and a high amount of exposure. But what exactly do these numbers mean in terms of the amount of green space around them? I'll just show you a quick example. This is where our study is interested in, Wales, and I'm going to quickly look at a few examples of exposure within Swansea, which is where I'm based. And here we have the levels again. So we've got a low level of exposure up to highest level exposure based on all the exposure values observed within our study. And if we're looking at a medium amount of exposure, we've got two mixed residential in greenness, and you can see it dotted around the amount of green space. It looks quite green around the area. But if we want to look at the highest amount of exposure, we've got Gower, which is an area of outstanding natural beauty, and you can see how predominantly green it is compared to this medium amount of exposure. And then if we look at low amounts of exposure, then we're looking at Swansea city centre and high dense residential areas where there's quite a big difference between the amount of greenness in that area compared to, say, the highest amount of exposure. What does the data look like in terms of mental health disorders? So what we're able to identify in terms of it being a longitudinal is whether an individual is identified at risk more than once during their time period in the study, and also the duration at which they are identified as at risk of a CMD. So for example, this individual here which is a complete example, has two distinct periods of CMD, and a total duration of 9 quarters where they are at risk of a CMD. In terms of the whole cohort, most people observe just one distinct period of CMD, but we do observe people who have two distinct periods, two or more distinct periods. So 35% of our cohort observe more than one distinct period of CMD. In terms of durations where they're identified as at risk of a CMD, you can see that some of our cohorts are identified as at risk for the whole duration that they're in and for the whole duration of our study. But we also could see that most people tend to be at risk of a CMD for less than 2 years, or that's what we are picking up in this study. And it is the males that seem to be mostly observing shorter time periods of being at risk of CMD. So what this data linkage has enabled us to do is to provide some initial insights, and it's great that we've got this huge rich data source of being able to link this environmental administrative data sources. We're going to take this and apply some multi-level modeling to quantify the impact of changes in this GBS access on individual level CMD and well-being. This is part of a much larger research team. I'm part of one work package within the team. We're a team working across numerous universities, and here is the whole team working on the project. Thank you very much for listening, and please do reach out if you have any questions. This is just a very brief overview of what we've been able to do so far, and I look forward to being able to share results with you in the future. Thank you.